which sort of bring inguinal hernias, incisional hernias, recurrent hernias, etc. And that to go through the details in terms of the pathology, the clinical presentation, and also the management. Before I give my comments, I don't know whether the colleagues have additions. So let me see. Dr. Tony, do you have any additions to the or comments?
Thank you, Professor. Thank you, Dr. Sebastian, for the wonderful presentation. I don't have any addition, so maybe someone else can give an addition. Thank you.
Okay, thank you. Dr. Fair?
Good morning. Everything has been.
Okay, thank you.
I'm not getting him.
Elaborated comment from the director. Thank you.
Yeah, he has a bit of difficulty with network, but I think he said he has no comment and he sort of felt that you had exhausted the presentation. Dr. John, do you have any comments?
Thank you very much, Sebastian. I had put my comment actually in the comment section. I needed a bit of clarification on the NIHAS classification of the inguinal hernias. Thank you.
Dr. Sebastian, do you want to respond?
Yes, let me go back. I think he meant this NIHAS classification of inguinal hernias. By the way, I didn't talk much about them, but the hernias are classified, they are classified into these types: type 1, type 2, type 3, and for type 3, we have type 3A, type 3B. For type 1, the indirect hernia with internal, for type 1, it is an indirect hernia with internal inguinal ring of the normal size. Let me hope he's getting me. Internal inguinal ring. So we are basing on the internal inguinal ring with its normal size. It is having the normal size. We know the normal size is supposed to be over 1 to 2 millimeters. The inguinal, the diameter supposed to be 1 to 2 millimeters. So you may find somebody is having the normal
Millimeters or
internal inguinal
centimeters?
ring. What?
Millimeters or centimeters? Millimeters is too small.
By the way, it is as if it is. It is centimeters. But where I read it was millimeters. I remember very well. It was millimeters, not centimeters. I read in Schwarz, it was 1 to 2 millimeters. You can also confirm. You can go there and read and to confirm. Then for type 2, indirect hernia with dilated internal inguinal ring, but intact posterior inguinal wall. I think this one is direct. I don't need to explain. Then we have type 3, whereby type 3 we have posterior inguinal wall defect. Remember, in the first and second, we don't have inguinal wall defects. So, but for the third, we have inguinal wall defect. Then type A, 3A, we have direct inguinal. Remember, type 1 and 2, we are talking about indirect. Then for type 3, now we are looking at the direct inguinal hernias. That's why we are not much even focusing on the rings, the inguinal rings. So we have type A, whereby type 3B, type 3B, this one again brings in indirect hernia with large dilated internal inguinal ring that encroaches on the posterior inguinal wall. This includes, as you can remember, pantaloon, the scrotal, and sliding hernias. Then we have type 3C. This is for femoral hernia. Then type 4. Type 4, we have recurrent hernias. Type 4A, we have direct. Type 4B, we have indirect. By the way, for type 4, we are looking at recurrent hernias. And for type 4A, we are looking at recurrent hernias in direct. And for type 4B, we are looking at indirect, at recurrences in indirect. Type 4C, we are looking at recurrences at the femoral hernias. In type 4D, we have combined. I think maybe Professor can add. That's what I can say about this classification.
Okay, thank you for taking us through that NIHAS classification. Maybe before I comment, I don't know that Dr. Abubakar has any comments or additions.
Thank you, Professor, and thank you, Dr. Sebastian. I don't have comments, but it was a good presentation. And thank you, Dr. Sebastian. You remember a lot of things.
Okay, thank you for the comments. So today, as the presenters told us, we are talking about abdominal wall defects, inguinal hernias, incisional or recurrent hernias. This is a topic that encompasses a very wide range of conditions. If you look at the abdominal wall, the topic didn't specify whether the anterior abdominal walls or the posterior abdominal wall, but we tend to, you can think about them in both ways. But the essence is that wherever you have a defect in the anterior abdominal wall, then you'll have an anterior abdominal wall herniation, which manifests in the different types that the presenters told us. Beginning with, if you look at the neonates, it may present as an omphalocele or a gastroschisis or a congenital umbilical hernia, or they may present as adult umbilical hernias or parumbilical hernias. And if the defects occur following surgical interventions, like following laparotomies, following C-sections, following laparoscopic surgery, then these ones present as incisional hernias. And if the defects are in the groin covers the inguinal hernias and also the femoral hernias. But definitely there are other hernias which are not so, they are common, but maybe not so mentioned a lot, like the Spigelian hernias. And definitely these, you are going to find them among the elderly. They will come to you in the OPD. And then on some occasions, you'll have the lumbar hernias, which are defects in the posterior wall. There are other hernias which are not part of the defects of the anterior abdominal wall, like the obturator hernias, the gluteal hernias. But just to keep at the back of your mind that these herniations also occur. Now, to go back briefly into the anterior abdominal wall defects, as the presenter mentioned, that we should have looked a bit more into the embryology of the anterior abdominal wall. But to begin with, after the embryo has formed, a lot of mechanisms are going on, body multiplication and organ formation. But specifically for the formation of the internal organs, usually by the 6th week of gestation, the increased length and size of the abdominal viscera pushes them out of the abdominal cavity. So they cannot be contained in that abdominal cavity because of the rapid development. So nature pushes them out of the abdominal cavity at about the 6th week of gestation, and then they develop outside of the abdominal cavity until about the 10th week of gestation. So after the 10th week of gestation, these organs should be able to retract back into the abdomen. Now, if this process is inhibited by some sort of mechanisms, and these organisms, this viscera does not move back into the abdomen as required, and it remains outside of the abdominal cavity, that's how it comes to form an omphalocele. And because these organs are lying out of the abdominal cavity, the abdominal wall cannot completely close that area. Therefore, you have a defect, but a defect which has been formed because of the persistence of the abdominal viscera outside of the abdominal cavity. So that is an omphalocele, failure for the return of the abdominal viscera into the abdominal cavity, and it is usually covered with that covering, and the cord lies anterior to it. Actually, it is said that the contents of viscera remain within the umbilical cord. That is an omphalocele. Now, as opposed to the gastroschisis, the anterior abdominal wall is formed by these lateral folds, what we call the lateral folds. And these are supposed to move and meet in the midline to completely close the abdominal cavity. And that migration begins about the 4th week of gestation. Now, if this migration does not happen, then there will be a persistent defect in the anterior abdominal wall. And usually it occurs around on the side of the umbilicus. So if that migration does not happen by the 4th week, it will be delayed. So the organs will be back in place, but then there will be incomplete closure because of the delayed migration of the lateral folds to completely form the anterior abdominal wall. The presenter gave us the international statistics, as you would say, but you need to add some of the studies which have been done in Uganda. There's one study which was done by Daniel Mompe Mwanja. It was 2019, where they looked at the different congenital anomalies around hospitals in Kampala, Mulago, Nsambya, Rubaga. So they came up with a distribution of congenital anomalies among neonates in these hospitals. And they found that 5.3 of these neonates were born with an omphalocele, and 2.4 out of 10,000 live births were born with a gastroschisis. So that gives you a picture, at least on a national level. It may not be representative of the whole country, but in that region. So you can quote that as part of the epidemiology in Uganda.
Okay, doctor.
And then another publication by Anne Wesonga, I think that was in 2015, followed up neonates who had gastroschisis. And in this follow-up, she found that 98% of the neonates were born with a gastroschisis and presented to Mulago Pediatric Surgery Unit, presented within 12 hours, but 98% of them died. So there is a very high mortality for neonates born with anterior abdominal wall defects in our setting, or in that way you could call it a high or low income setting, compared to neonates who are born in the high income countries. In the high income countries, the mortality rates are about 3 to 5%. in our situation, the mortality rates are 98%. So this is again something that you need to add on your epidemiology, or as you talk about anterior abdominal wall.
Okay.
Yeah, because they like to present in these neonates.
Okay.
Now, again, it is important to add that a third of the neonates who present with umbilical and inguinal hernias present with strangulation. Again, this was a study done in Uganda, the pediatric unit. So that shows you the dynamics of disease in the country, the magnitude, at least around Kampala, the mortality rates, and the predisposition to obstruction or strangulation among these neonates who present with umbilical hernia, anterior abdominal defects, and then umbilical and inguinal hernias. But on a broader sense, you can also look at what is it in the other African countries. Maybe there is other literature, and also you look at the global scale. Now, in terms of management, usually in our setting, let me begin with our setting. If there are other factors that these children are born with who have omphalocele or who have gastroschisis. Some of them are born with they're born premature in most cases. They are born with other congenital anomalies. And because of these factors, there are limitations in offering them anesthesia. But also the surgical skill may be lacking on how to handle such defects. So what we do in our setting, we use the non-operative treatment until the children at least about 6 months, when they can stand anesthesia, to have a definitive closure, if that is possible. So immediately after birth, application of a wet gauze on the omphalocele or gastroschisis will help. Application of a bag, like in our setting, I use the urine bag to protect the contents. And definitively, we use zinc oxide. So zinc oxide forms like a clay. It is like clay. It dries up, it protects the area, and by the time it falls off, there is a complete epithelialization, so that you have a defect which is covered by skin, and therefore you can deal with it as if you're treating a hernia. But that allows for the child to grow. As the child grows, the contents which were lying outside migrate further into the abdomen, because as the child grows, the anterior abdomen, the abdominal cavity expands. And as it expands, more of the contents that were outside move into the abdomen. And by the time you close the defect, you are basically managing the defect. The problem, if you try to attempt to close these contents into the abdomen of a neonate, the babies breathe with the abdominal muscles. So there's a lot of tension and pressure in the abdomen, so they will not be able to breathe, and then they'll die because of respiratory compromise. So that is why, to be able to correct this, you need to have other modalities of surgery, like in the high-income countries, where they can bring in sort of like artificial flaps and artificial things to expand the abdomen to be able to cover these defects. But also, the other difference is that in most of the mothers who attend antenatal and they have a chance to access ultrasound, this diagnosis of an omphalocele or a gastroschisis can be done by the 14th week of gestation. Once a mother gets a scan, they will be able to identify these contents lying outside. And therefore, there is a chance to plan on the management of this child as you follow it up in the process of antenatal. In our setting, access to ultrasound is limited, and many mothers, these events are discovered at birth, and then you begin planning on what to do. So that is the management for this omphalocele and gastroschisis. Non-operative treatment: apply zinc oxide until the contents of epithelialization has taken place and the contents have migrated. Then you deal with the defect, and also at a time when the child can ably stand anesthesia, so that you basically deal with the defect, which is in the anterior abdominal wall. Then for the umbilical hernias, congenital umbilical hernias, as the presenter said, we take the principle of 2 years. We assume that these defects should close by 2 years of age. If this defect has not closed by 2 years of age, then it will not close. So you have to now decide on the surgical closure, depending on the interests of the parents, your interests as a doctor, and also the interests of the child. So that's when the discussion has to be taken to decide on when can you safely repair this defect. But once it passes 2 years, then spontaneous closure is almost limited. Now, we shall turn our focus to the groin hernias, where we refer to the inguinal and the femoral hernias. As the presenter mentioned, inguinal hernias pass through the inguinal canal, and the femoral hernias are located in the femoral canal. The presenter told us about the Hasselbalch's triangle, and if the hernia is within the Hasselbalch's triangle, then that is an indirect hernia. If it is outside of the Hasselbalch's triangle, then that is an indirect hernia. Hasselbalch's is direct hernia. Outside of Hasselbalch's is indirect hernia. Now, it is important as USHOs to understand the importance of these hernias. As you know that the burden for groin hernias is huge. I think in most of the outpatient clinics, you will see the biggest number of patients that you will see are patients with inguinal hernias or groin hernias. It is one of the commonly performed surgical procedures globally, with over 20 million procedures globally. In our setting, a number of people move around with inguinal or groin hernias. They are not treated. They cause pain. But these hernias can be treated under elective arrangements, but still access to care is limited. So many people move around with the hernias untreated. And then they present in the emergency situation. And once they present in an emergency situation, then the risk of morbidity increases, and also the risk of mortality increases. And because of that, it becomes a public health importance that a condition which should have been treated electively, which is quite numerous, which is quite evident in a big population, now turns out to be an emergency which can even result into loss of life. A hernia repair performed in an emergency situation consumes more items, something that you should have done under local anesthesia or regional anesthesia. You have to use general anesthesia. A patient whom you'd have operated and goes home on the same day, maybe the following day after surgery, may have to be admitted for many days. Some of them may have to undergo resection and anastomosis, requiring more means of treatment, IV fluids, antibiotics. And then when they come with a lot of compromise, they may easily get bad outcomes of surgery. Complications increase in emergency surgery, like wound infections, and also anastomotic breakdowns are also common, which again worsen the outcome of the patient. Consider groin hernias as a public health issue. Now, inguinal hernias are more common in men than women, but also among women, inguinal hernias are more common than femoral hernias. But if you compare femoral hernias between women and men, then women present more with femoral hernias as compared to men. And the presenter gave us some of the factors that lead to formation of femoral hernias, or the high predisposition of femoral hernias in women. The factors that lead to formation of inguinal or groin hernias are numerous. The presenter went through some of them. Some of them are familial. There's a very strong relationship between family and acquiring a groin hernia. Some of them are congenital. They are born with them until later. Connective tissue diseases, smoking, previous hernia surgery. Okay. So it is important that you are acquainted with the factors that lead to the formation of femoral hernias and also the inguinal hernias. The presenter took us through the anatomy for the inguinal hernias, the inguinal canal, its walls and borders. That is very important in terms of surgery, because it is very difficult to operate on a hernia if you do not know the anatomy of the hernia. You don't know where the anterior wall is, You don't know where the external oblique is. You don't know where the conjoint tendon is. You know, you don't know the contents of the sac. So this is parts of anatomy that I'll request you to read again and make sure you are acquainted well with the location of these structures. And once you have a chance to operate, to also be able to identify them properly, so that you truly know where the conjoint tendon is, the ilioinguinal nerves, the iliohypogastric nerves, the contents of the cord, identifying the vas difference. This is the chance for you to really operate and appreciate these structures. But again, as surgeons, you remember that there are variations in the anatomical presentation of some of these structures, like the nerves, the ilioinguinal nerves and the iliohypogastric nerves. The consistency of their anatomical positions is about 40%. The rest of the 60% have an inconsistent anatomy. So you have to rely on structural identification to be able to identify them. And it is very, very important to leave those nerves intact, not to suture them, not to cut them during hernia repair, as a way of preventing chronic groin pain, as we shall see in the complications. So if you don't identify these nerves, you will cut them, and then the patients will get complications, as we are going to see. It is very important to identify the vas difference, because if you cut the vas difference, you automatically sterilize the patient. If you injure the testicular artery and the pumpiform plexus, then you end up with an atrophic testis, so which again sterilizes the individual. So it is very important that as you perform the surgery, you have the capacity to identify these organs properly, so that you leave them intact as you found them. The presenter took us through the differentials for the hernias. Again, I'll ask you to dwell on them. Is it a congenital anomaly? Okay. Is it trauma? Maybe a hematoma? Okay. Which will definitely be of acute onset. There was an event, there was injury to the testis, and now the child has a swelling, or a person has a swelling, or he was kicked as they were playing and has a testicular swelling. Okay. Is it neoplastic? Maybe it is a testicular tumor. Okay. And you need to have all this at the back of your mind to be able to decide that, yes, you are dealing with an inguinal hernia, or you are dealing with something else. Is it a hydrocele, as we commonly see in children and also adults? So, but these are differentials that you need to have, or it's an orchitis, didymochitis. So you have to have the techniques of differentiating these differentials from a hernia. Now, usually we say that diagnosing inguinal hernias is a clinical diagnosis, but you need to know the modalities of investigations which can be done. You can use a groin ultrasound, sonography. This one has in some literature talks about a sensitivity of 100% and a specificity of 80%. You can also do CT scans. CT scans tend to have a high sensitivity close to 90%, but a low specificity of 60%. So if you compare these, but a CT scan will have a higher specificity and sensitivity if there's intestinal obstruction. And but the essence here is to guide you on what are the necessary investigations. Definitely you want to have an investigation which has a high sensitivity and a high specificity. And ultrasound is easily available. As I mentioned, I don't know that I mentioned it to you, that it is now the ultrasound, the stethoscope of the 21st century. So many people move around now with these portable machines. So you may have a difficult diagnosis, and an ultrasound will be a very good tool to add on to your investigative capacity. If there are features of bowel obstruction, you can still diagnose this with ultrasound. Now, in terms of treatment, there are general principles that we use. Among women and men, and women and children, once they are identified with a groin hernia, which could be inguinofemoral, and you have the capacity to operate, which means you have the surgeon, you have the theater and anesthesia, you need to schedule these appointments as soon as possible. Why? Because of the high chances of obstruction and strangulation that is seen in children and women. So that's a general principle. For men, we have an option of watchful waiting. If the hernia is not painful, okay, and someone can go ahead with their work with the hernia, but they also have a capacity to reach hospital in time in case of an emergency, then you can use the option of watchful waiting. But again, literature shows that the conversion rate into surgery is between 10 to 60%, more so with increasing age. So you cannot, definitely, like in our setting, you can't operate on every hernia that exists. It will take you many years to operate on that huge burden of hernias that exist. That's why we have that principle of watchful waiting. But in a hospital setting, once a patient comes to the surgical outpatient and mentions that they have a hernia, then we have to schedule them for operation, because they have, by the time they present to you, then most likely they have pain and maybe discomfort. And that's why we offer them the chance to operate them as elective cases. We cannot send them back and say, okay, go back and wait for 1 year if you get pain. No. Once they walk from home and come to the hospital, that means they demand for treatment. And that's why we offer them the surgical approach for treatment. The presenter told us about the approaches. You can use a herniotomy, you can use herniorrhaphy, you can do hernioplasty. Now, herniotomy, as the presenter said, is basically the ligation, transfixion, and excision of the sac. And this is basically what we do in children. And for children, we mean up to 18 years. There is a gap or a margin between 16 and 18 years. But what I do, less than 18 years, I only narrow if the internal ring is very wide, then I'll put a suture to narrow that internal ring. And herniorrhaphy will begin after 18 years. That's when you repair the posterior wall. And the presenter told us about the methods of repairing the posterior wall, the modified Bassini, the Shouldice, and the Desada method. The Shouldice method is the best tissue-based method. It has a very low recurrence rate. But this success is only in the Shouldice Education Center in Canada. That's where they have very good success with Shouldice repair. In other centers where they have tried to perform Shouldice, they don't get good outcomes as in this Shouldice center. Why? Because teaching Shouldice is not passing on knowledge and transfer. There is a drop in acquiring knowledge. There's a deficiency in capacity to acquire knowledge. And that's why it became the modified Bassini was widely spread, but also it has a problem of a high recurrence rate, which ranges between 50% to 10 to 50%. You can get a recurrence with the modified Bassini repair. But it is easier to teach and to perform than a Shouldice repair. And that's why many doctors, through training and even when they qualify, their colleagues are doing the Bassini. But it also has a problem that when you talk about the modified Bassini, many people mean different things. So that is one of its challenges. But it's easier to show that this is the inguinal ligament, this is the conjoint tendon. So these are the areas that you use to support the posterior wall. So it is easier than to teach the Shouldice repair. Now, the presenter mentioned about the Desada method, where we use the external oblique, that flap of the external oblique. We suture the lower part of it to the inguinal ligament and the upper part of it to the conjoint tendon. It has been actually, a few studies have compared it with the mesh repair, and it shows a very low recurrence rate, almost 1.5%, 2%, which is almost the same rate like a Liechtenstein repair. But its drawbacks are that some people have a very weak external oblique. Some people lack the conjoint tendon or a very weak conjoint tendon. And it would almost, at times in recurrences, it is almost very difficult to mobilize that flap for the inguinal ligament, the external oblique. So those are drawbacks for the Desada method. It can only be done per individual. It depends on the individual, your patient, and it will depend on your findings in the operating room. Now, in a case where you have to plan on what to do and what to use, you don't want to go with that kind of mind in the operating room, or what going to patient asking you, yes, how are you going to repair my hernia? And you are not sure. So yes, it is a good method. It is easy to perform in a good patient, a young patient who has a good external oblique, a good conjoint tendon. It is a very good method. You can easily do it, but it has those drawbacks. So Dr. Sebastian said he has chosen it as his method. but I'll be able to, we shall discuss a bit more and maybe have chance to work around it. And you see these challenges that you face with this method. Now, the Liechtenstein method, as we know, the anterior mesh repair is a very good method, very low recurrence rates. But of course, it has also changed a lot. Many people talk about Liechtenstein and they mean different things. Over different types now of doing Liechtenstein, over 100 different ways of performing Liechtenstein. And then we have a problem with this Liechtenstein, the reactions and to the mesh. Actually, one of the biggest challenges is the chronic pain that almost 15% of patients who undergo Liechtenstein repair develop chronic groin pain. And they have to either stay on medication for long, they have either to get the mesh be removed. Some of the pain resolves spontaneously, and some of them have to live with very chronic pain for long. So that's a drawback, chronic pain, reaction to the mesh, so the mesh has to be removed. And what now is being advised, they are developing newer types of mesh which can easily be used. They are absorbable types of mesh which are being developed. And they think that by getting these absorbable types of mesh, then you can reduce the complications of chronic pain and tissue rejection. But it is good because it is easy to teach that this is the conjoint tendon, this is the inguinal ligament, fix the mesh here and there. So it is something that can easily be taught. Actually, some studies have even taught it to clinical officers, and they are performing with the same outcomes as surgeons and medical officers. Why? Because you are only placing an item. You just show them that this is the conjoint tendon, this is the inguinal ligament, fix this mesh there. And so it is easy to teach, to transfer knowledge. It is quite easy. And so far it has very good outcomes and low recurrence rates. But its drawbacks are chronic pain and rejection. Those are the challenges that we have with it. The presenter talked about the laparoscopic approaches. You haven't had an exposure to these, but you can read about them. You can view them on YouTube so that you see how this is being placed. They are good because now they are being performed as day case surgery. Patient comes in, the access is very minimal. They are definitely done under some sort of GA or sedation. Patient wakes up and goes back to home the same day. Very quick recovery because you only have small ports on the abdomen. So quick recovery and you go home. The only problem is the need for general anesthesia and of course the equipment and skill that you have to be trained in performing laparoscopy. You must be trained. You must have this equipment, theaters with this equipment, and also able to perform general anesthesia. Now, femoral hernias, as the presenter mentioned, they are very common in women. And he gave us those 3 methods for repairing the femoral hernias. The easiest one is the Lockwood or the low approach. And I think most of you are performing the Lockwood. The inguinal approach is a bit complicated. You have to go through the inguinal canal and then you open the preperitoneal fat and then you go into the femoral canal. But this one I will show you at one point. And also the MATOVU, it is good. It exposes both the inguinal and the femoral areas, but again, the dissection is a bit complicated. The MATOVU is not being done anymore, but it uses the conjoint tendon to cover the femoral canal. But again, to be able to perform this MATOVU, you need to use the inguinal approach because you have to expose the conjoint tendon, open the preperitoneal space, go into the femoral canal, and you fix the conjoint tendon onto the Cooper's ligament, then you cover that femoral defect. But this one I will show you when we get a chance to work together, just to demonstrate to you some of these. Now, in the high-income countries, the recommended approach for repairing groin hernias in women is the laparoscopic methods. Either use the tape or the tap. That is for the high-income countries. In our situation, we don't have these methods, and therefore we still use the anterior open approaches. Either use the inguinal approach or use the transinguinal, the lock approach, or use the transinguinal approach. That's what we have in our setting. But maybe by the time you qualify as surgeons and some of the centers you'll work with, they will be using laparoscopic or other endoscopic methods. So, but I've given you the advantages of these, with the laparoscopic and then the open approaches. They have open approaches are easy to do under local anesthesia. Patient comes in local, you operate, they go home. But then endoscopic approaches, you need to have general anesthesia. Let me speak briefly about the incisional hernias. These incisional hernias, as you know, occur basically following a previous surgery or laparoscopic surgery. But in our setting, we see them after previous operations. And the reason that they occur is, one, the technique. If you don't repair that laparotomy very well, if you don't repair that incisional hernia properly, I mean C-section, cesarean incision properly, then you'll get a recurrent hernia. There's a principle that we really teach for preventing, making sure that you repair your incisions properly and most of the rectus sheath. So it should be 0.5 millimeters between the sutures. Even the margin from the rectus sheath should be 0.5 millimeters. I know that someone has taken you through this before, but for the people in Mobenda, I will definitely show you this so that you learn how to repair the sheath properly. So if you don't repair that sheath properly, you're predisposed to getting incisional hernias. If sepsis sets in, then you are predisposed to getting incisional hernias, because sepsis hinders collagen formation. That's how incisional hernias come to develop after sepsis. But also, in some cases, you have a effect on the deposition and collagen, the healing process can be hampered by early physical activity, by the age at which the patient is getting the operation, the nutritional status, okay? So people who are malnourished will definitely not get a good wound healing. People who are obese will not get good wound healing. And therefore, these will result into incisional hernias. As the presenter told us, once these are identified, you can use the Mayo's repair. But what I do is the Keel procedure. That is a very good procedure. I'll show it to you. It forms a very, very good strength of repair. Keel is K-E-K-E-L, Keel's procedure. It is very good for repairing incisional hernias. Definitely studies have been done comparing the Keel and the Mayo, and they don't see a lot of difference in these two procedures. The Keel takes longer, it consumes more sutures. The myos is shorter and it uses less material. It is simpler. So not many people are doing the kill procedure today. They have gone back to the myos, even for incisional hernias. And of course, in centers where they have the mesh, then the mesh is now like the standard for treating incisional hernias. But again, as we mentioned, with the challenges of the challenges of the mesh, they also occur in patients with incisional hernias. I think we lastly talked about the NEHAS classification. I really don't have any much to add on the NEHAS. A lot of literature there is on NEHAS classification, but I think basically it is to know the classification. Just to know the classification. I think that is the most important thing that you need to know about the NEHAS classification. There's a lot about hernias. We could have spoken a lot more for an extra 1 hour, but I've tried to pick out the most important things that I thought I would sort of add on to the talk. But definitely we shall discuss more things in the practical sessions. It is very interesting to work on hernias. There will be the most common conditions you are going to face, and you're likely to have the skill to repair hernias properly. So thank you very much, Dr. Sebastian, for giving us the presentation today. I see that the next talk would be on the diseases of the retroperitoneal space, again by Dr. Sebastian.